insulin was raised, and we had to start drugs also. And then, as was on feeds, we tapered and baby discharged. Another case is an interesting case as the cause is different. This is a case of symptomatic persistent refractory hypoglycemia. Baby required GIR of more than 20 milligram per kg per minute for more than 10 days. Day of life 6 to 16. We used it by using 25% dextrose given via central line, and oral feeds were also given at 60 to 100 ml per kg per day. So despite an extensive workup in this case for metabolic and endocrine causes, all evaluations were negative and sepsis was identified as the underlying etiology. The clinical course demonstrated a cause-effect relationship, as during worsening sepsis, infant required exceptionally high GR to maintain euglycemia, whereas with resolution of infection, hypoglycemia improved and GI requirements gradually declined, and baby was successfully transitioned to full feeds. So this case highlights sepsis as an important reversible cause of refractory neonatal hypoglycemia. Okay, so first was infant of diabetic mother, hyperinsulinemic. Second as sepsis cause of neonatal hypoglycemia. In both these cases, our approach was these were symptomatic infants. Both had hypoglycemic seizures with us. We gave fluid bolus 2 ml per kg of 10% dextrose, which is 200 mg per kg. Then the bolus followed by continuous infusion GIR at 6 to 8 mg per kg per minute. Since blood glucose will be checked after 30 minutes, then every 6 hours until glucose is more than 50. In our both cases, it remained below 50 despite bolus and glucose infusion. So the GIR was increased in steps of 2 mg per kg per minute every 30 minutes until a maximum of 12. In one case, we had given more than 20 mg per kg per minute also. All right, this is a flow chart. Again, symptomatic, including seizures, right arm of my picture. We gave bolus followed by that infusion. Then still, as blood glucose was less than 50, we increased GIR by 2 mg per kg per minute. And till euglycemia, we give more than 12 mg per kg per minute. Again, we sent critical samples. We took reference consult also endocrinology, and we gave drugs also, hydrocodone diazoxide in our cases. All right. So there is enteral feeding strategy also in refractory hypoglycemia. Once baby is stable for 24 hours on IV fluids and two values are above 50 mg per deciliter, we wean by 2 mg per kg per minute. And once GIR is below 8, we can start oral feeds, but we do monitor RBS 6 hourly. Once rate is 4 mg per kg per minute, we stop IV fluids and baby is on full feeds. Further monitoring is stopped after two values. We do not continue monitoring RBS once baby is on full feeds and IV fluids are stopped. Now, tapering of medications is done once baby is on full feeds and euglycemic. All right, in the end, I'll go through this standard treatment workflow. Whom do we screen hypoglycemia? Preterm, less than 37 weeks. Low birth weight, small for gestational age, large for gestational age, infant of diabetic mother, sick infants having sepsis, asphyxia, respiratory distress, shock, polycythemia, seizures, post-exchange blood transfusion, or infants on IV fluid or parenteral nutrition. Basic at-risk schedule is 2, 6, 12, 24, 48, 72 hours. And if the baby is on IV fluids or TPN, we do every 6 to 8 hourly. Again, if glucose is less than 45, we look for symptoms, autonomic symptoms or neuroglycopenic symptoms. So stupor, lethargy, limpness, jitteriness, tremors, convulsions, episodes of cyanosis, apnea, weak or high-pitched cry, or difficulty in feeding. Yes, all right, second arm, if baby is symptomatic and blood glucose is less than 20, or baby is asymptomatic, but even after feeds, glucose is less than 45 only, then we give infusion. We recheck blood glucose every 30 minutes after starting GIR of 6 mg per kg per minute. then every 30 minutes till euglycemic, and then 6 hourly. If baby has less than 45 only, we increase GIR in increments of 2 mg per kg per minute till maximum of 12. Then we label it as refractory hypoglycemia, more than 12 mg per kg per minute for 24 hours, or persistent for more than 7 days, GIR requirement. Then we send our critical samples, then we take our consents, and then we go ahead with our drugs diagnostic pharmacological management. So for drugs management, I'll request my colleague to go ahead with the management of drugs. And that's it. Thank you. Any questions?
Thank you, Dr. Disha.
Thank you, sir.
I think I'll request Varia team to please take over now for the
Yes.
pharmacological management.
Good morning. Today we'll be discussing some cases which we have encountered in our NICU. So first we'll go briefly about the approach for hypoglycemia, which
Pooja,
She's
go
pretty
full
Pooja.
screen, no?
Yeah,
Full
please,
screen.
please.
Yeah, put it on the slideshow. Yeah, okay.
This has been already discussed in short, but I'll go briefly. Hypoglycemia, first, in the first 48 hours, if the BSL is less than 45, or after 48 hours if it is less than 60, depending upon the symptoms, that is neuroglycopenic or neutropenic symptoms. If the baby is symptomatic, yeah, whatever, and the BSLs are less, then we'll give out 2 ml per kg of the dextrose 10% bolus. If the baby is asymptomatic, but if it is less than 25, then only we'll give the bolus. If it is more than 25 to 45, we'll try oral feeds, which is on the right arm. We'll monitor feeds for monitor HGTs every 1 hourly. If the HGT goes above 45, we'll feed quantified feedings, measured feedings frequently, and 6 hourly HGT monitoring. HGT of more than 45 for 24 hours, and we can stop monitoring after 48 hours. After in symptomatic or asymptomatic but less than 25 HGT, 2 ml per kg of dextrose 10% bolus, and followed by IV fluid bolus, maintenance bolus of 6 mg per kg, and monitor every 30 minutes. If the HGT goes above 50, we have to monitor 6 hourly, and taper by 2 mg per kg per minute every 6 hourly until 4, which is minimum, and then we can transfer to oral feeds. If the HGT is less than 50 after GIR or IV infusion of GIR 6 mg per kg per minute, we can increase to 2 mg per kg per minute of GIR and monitor every 30 minutes. This is a diagnostic approach in non-transient hypoglycemia. We have to, if there is an episode of hypoglycemia, measure, have to send sample for insulin, ketones, bicarb, and free fatty acids. If the gases show if the ABG shows no acidosis with decreased ketones and free fatty acid, we can think of genetic hyperinsulinism, hypopituitarism, transient hypoglycemia, and perinatal hyperinsulinism. If the ketones are less with increased high free fatty acid level, we can think of FAODs. With acidosis presence and high lactates, gluconeogenesis defect. With acidosis and with increased ketones, GSDs, cortisol deficiency, growth hormone deficiency, and cortisol deficiency. Some points which needs to be noted before for any cause of hypoglycemia. The maximum dextrose concentration which when give through a peripheral IV line is only up to 12.5%. So IV access has to be sorted out. Secure central line UVC or PICC for requirement of GIR more than 8 mg per kg per minute. For cases requiring GIR more than 8, ensure there is a patent line before considering refractory hypoglycemia. Bolus needs to be followed by GIR infusion from 6 to 8 mg per kg per minute to avoid rebound hypoglycemia. The target glucose levels we want in high risk newborns without a suspected congenital hypoglycemia in first 48 hours of more than 50, and above 48 hours we need more than 60. Neonates with suspected congenital hypoglycemia disorders and those requiring IV glucose to treat hypoglycemia, it should be more than 70. This formula, many formulas have been explained. We'll go with the case. First case is 10 days male child, 36 weeker, 3.9 kilos, born to 32 years, para 3 live 1 with 2 deaths. Non-consanguineous marriage, LSCS due to previous 2 LSCS, came to casualty with history of first death was first baby died in 2012 where the antenatal history was uneventful. Full term LSCS 4 kilos female child with microcephaly, seizure at day of life 4 and 5, expired at 1.5 to within 1.5 to 2 months, and there were no documentation available as for the cause. Death 2, second child died in 2014. In antenatal history was again uneventful. Full term LSCS male, 3.2 kilos, seizure at day of life 4 with hypoglycemia, neonatal sepsis, and expired at the same time. In the present pregnancy, the antenatal history is uneventful. This baby was born by emergency LSCS with previous 2 LSCS and with bad obstetric history, had thick meconium stained amniotic fluid, male child 3.9 kilos, and baby had cried after birth. Before transferring to our hospital, the outside hospital history, which is in short, baby was born in some private hospital in Jalna, shifted to another private hospital due to respiratory distress. Non-invasive mode of respiratory support was provided to the baby due to due to repeated episodes of hypoglycemia. Diazoxide and octreotide was started outside. Doses and the courses was not mentioned. Baby had convulsion for which anti-epileptics was started and abnormal EEG was documented. Sepsis screen was positive and antibiotics were escalated to meropenem and colistin. Baby took discharge. Baby took DAMA and was presented in casualty with the following measures. Airway was not maintaining breathe. There was no spontaneous respiration. Saturation was not recordable. Circulation pulses were not felt, and HGT was low. So immediately CPR was done, resuscitation was done, baby was intubated, and return of spontaneous circulation was achieved. D10 for the for the low sugars, dextrose 10% of 2 ml per kg, with and followed by IV infusion with GIR of 10 with volume of 150 ml per kg per day was started. Baby was immediately shifted to NICU. For the past pregnancies, initially no documents were provided by the parents. Baby was on invasive ventilation. IV fluids were continued. For sepsis, in our center, we have started cefosulbactam, colistin, and flucon. On admission, the sugars were again low in spite of the continued IV fluids during transport, and proper IV access was gained. The dextrose 10% of 2 ml per kg bolus was again given, and the volume was increased to 180 with GIR 12.1. Baby also had one episode of convulsion for which levetiracetam was loaded. Sugars were checked within half an hour. Again, the sugar HGT was low. To maintain the sugar level, GIR was increased gradually to 25, and the critical sample was sent in view of refractory hypoglycemia. Glucagon challenge was performed during the critical sample we'll discuss later. Glucagon challenge was also performed during hypoglycemia, which showed a rise in sugars more than 30, which is an indication of hyperinsulinism. Critical sample showed random blood sugar of 16 and insulin 301, which is a very diagnostic marker for more than 2 is an indicator of hyperinsulinism. The as the cause for hypoglycemia due to high levels of insulin and previous sibling death to the similar causes. Genetic, metabolic, syndromic, or transient causes of hyperinsulinism was in the loop. On arrival, as the baby was not on fluids and was not fed recently prior to the admission, hypoglycemia was thought might be because of prolonged fasting or might be sepsis related. Later, due to refractory hypoglycemia, as the GIRs were increasing, the critical sample was sent, was discussed, and which showed hyperinsulinism. The following documents were presented next day. The best of the chorionic villi sampling, which was done for this baby antenatally, showed ABCC8 mutation of chromosome 11. Then the Sanger sequencing of the chorionic villi sampling of the mother and father were done, which again showed ABCC8 mutation along with other mutations which were evident in the first death, which showed microcephaly and seizures. Then the diagnosis of congenital hyperinsulinism confirmed because of ABCC8 mutation, and C-peptide was also sent, which was 8.49, which is a diagnostic marker for congenital hyperinsulinism. Endocrine opinion was sorted for the acute period. They had started with hydrocortisone 2 mg per kg per dose and glucagon infusion just to for the GIRs to rise. Minimal enteral nutrition was started on the day of life 3, on day of admission 3, with 20 ml per kg per day and GIR of 25, gradually decreased to 21.6 over the day. First, we have tried diazoxide 25 mg stat followed by 25 mg per kg of TDS, but it was unresponsive. Then injection hydrocortisone was given to increase for the acute case. In the feeds, to increase the caloric requirement, the feeds were increased to 60 ml per kg per day with 1 gram of cornstarch and 1 gram of sugar with total GIR of 15. Injection octreotide was tried. 10 micrograms initially subcutaneous route was tried, but it was not responsive. So we tried IV infusion octreotide, which showed positive response and eventually shifted to subcutaneous octreotide again. EEG was done again in view of convulsions, which was encephalopathy. Patient was extubated within 2 to 3 days of admission and later tapered to CPAP. And presently the baby is on room air. Here, the cause for refractory hypoglycemia, which was seen, is congenital hyperinsulinism. Drugs that we have tried on day 1 were glucagon infusion, hydrocortisone in the acute phase. Diazoxide was started, but it was unresponsive. So responsiveness to diazoxide depends upon the genetic type which has caused the hyperglycemia. Octreotide was started, which was responsive. Genetic mutation confirmed by WES on ABCC8 mutation on chromosome 11, and target HGTs were within 70 to 120 mg per day. Further plan of management for this case: mother will be trained for HGT monitoring and technique of subcutaneous injection of octreotide before discharge to manage at home. Plan is to manage the baby on pharmacological treatment, but exidin scan is to be planned and if required, near total or total, depending upon the diffuse or focal lesion on the pancreas. The near total or total pancreatectomy can be done. We'll discuss a few points on parenteral glucose infusion. Dextrose 10% bolus should be given if symptomatic hypoglycemia is present, or asymptomatic if it is less than 25. In some instances, a repeat bolus may be required, but further repeated more than 2 to 3 boluses should not be tried, as bolus of glucose is a potent trigger for insulin secretion. Normoglycemia should be achieved by delivering a continued IV glucose infusion starting with 6 to 8 mg per kg per minute. Many patients with hyperinsulinic hypoglycemia may require more than 25 mg per kg per minute of IV glucose infusion and to maintain normoglycemia. The glucagon challenge test, which we have done in this patient, is a diagnostic procedure used to assess if there is an issue with congenital hyperinsulinism, in which the pancreas produces too much insulin, leading to dangerously low sugars. The test measures the child's blood sugar response to an injection of glucagon. If the blood sugar rises more than 30, it strongly suggests congenital hyperinsulinism. Glucagon administration. Glucagon is a key counter regulatory hormone and is used as a first line therapy for managing CHI patient, particularly in emergency situation, which we had here, where the patients are unable to take oral feeds and IV access is difficult to obtain. Glucagon in short term induces glycogenolysis, gluconeogenesis, and lipolysis, and causes a rapid increase in plasma glucose within a few minutes after administration. Recommended dose is 0.5 to 1 mg via intramuscular subcutaneous injection. Glucagon in high doses over 1 mg can cause rebound hypoglycemia due to paradoxical increase in insulin secretion. Therefore, it should be given for a short period of time and only given in emergency cases. Frequent feeding. While weaning period, frequent feeding with high calorie carbohydrate feeds may reduce the frequency and severity of hypoglycemic episodes. However, patients with CHI, particularly those on diazoxide therapy, usually have food aversions. Therefore, a percutaneous gastrostomy is sometimes recommended to allow frequent feeding. Using complex carbohydrates such as uncooked cornstarch may decrease the hypoglycemic episodes. We'll discuss few things about diazoxide. How does it work? Diazoxide functions by binding to the SUR1 subunit of the potassium channel. Thus, it requires a functional potassium channel. A diazoxide unresponsive CHI, urgent genetic analysis for ABCC8 or KCNJ11 and DOPA PET scan are indicated to identify which patient have the focal form of CHI. In a recent study, diazoxide responsive patients with CHI who carry paternal inherited ABCC8 or KCNJ11 mutation have been reported, and it was suggested these patients should also undergo scanning for DOPA or PET scan. Now, diazoxide, if this is a represent, the glucose enters via the GLUT2 transporter, and it is subsequently metabolized, producing ATPs. The increase in ATP ADP ratio closes the potassium channel. The depolarized beta cell membrane leads to opening of the voltage gated calcium channels. This rise in the intracellular calcium triggers insulin exocytosis, and in contrast, the diazoxide opens up these potassium channels, which hyperpolarizes the calcium channels and inhibits insulin release. The initial dose of diazoxide is 5 mg per kg per day in 3 divided doses, which can be increased up to 15 to 20 mg per kg per day. The most severe side effects of this drug is fluid retention, cardiac failure, and associated electrolyte and imbalance and cholestasis. For fluid retention, we use thiazides, chlorothiazides. For electrolyte imbalance, monitoring of electrolyte should be done and appropriate corrections to be done. For cholestasis, GGTTP is to be monitored. Diazoxide induced pulmonary hypertension is another life threatening side effect which requires treatment withdrawal. For thiazides, in newborn period, thiazides, that is the chlorothiazide, can be used in 7 to 10 mg per kg per day in two divided doses. This it causes hypo. This can prevent fluid retention and synergistic effect with diazoxide on potassium channels to inhibit insulin secretion. It has side effect like hyponatremia and hypoglycaemia. Octreotide. Octreotide, it is an 8 amino acid synthetic long acting somatostatin analog that inhibits insulin secretion by binding to the somatostatin receptors, that is the SSTR2 and SSTR5 receptors. Activation of these receptors causes decrease in the insulin gene promoter activity, inhibits calcium mobilization, and affects the and also inhibits the acetylcholine activity. Somatostatin also inhibits potassium channel, which results in reduced insulin secretion. The recommended initial dose is 5 microgram per kg per day, which is given by subcutaneous injections. Can also be tried by continuous IV infusions at interval of 6 to 8 hours, with maximum dose reaching up to 30 to 35 microgram per kg per day. The long-term continuous subcutaneous octreotide infusion with an insulin pump can also be reported as a feasible alternative to surgery for patients with monoallelic potassium channel mutation. The first response to octreotide is usually hyperglycemia, followed by a blunted effect after 48 hours due to tachyphylaxis. Thus, dose adjustments may be requirement intermittently. It was found a safe and effective measurement for diazoxide unresponsive CHI case. So this is a nomogram, or this is a flowchart for how to progress in cases of hyperinsulinemic hypoglycemia. We have to maintain normoglycemia by glucose infusion, octreotides, or glucagon. Sorry, diazoxide trial can be given starting at 5, reaching up to 20. If the case is diazoxide unresponsive, we have to investigate by sending VES for mutation analysis. If it is homozygous compound ABCC8 or KCNJ11 and diffuse lesion over the pancreas, then medical therapy or near total pancreatectomy can be tried, and the baby can be followed up with monthly octreotide injections and HGT monitoring at home. Then second, paternally inherited heterozygous ABCC8, KCNJ11, de novo mutations or no identified mutation, or DOPA PET CT scan to identify the focal form and if it can be removed, or it can be excised by partial pancreatectomy with regular follow-ups. If the case is diazoxide responsive, assess the fasting tolerance, discharge on diazoxide, and keep a follow-up. Case 2. A second child, 6 days male child, born to G3P2L2 mother by spontaneous conception with uneventful antenatal period and no maternal comorbidity. Antenatal scan was suggestive of oligohydramnios, intrauterine growth restriction, and increased uterine artery resistance. Birth details: 35-weeker emergency LSCS born to with PPRO and premature rupture of membranes for 8 hours. Male child cried after birth with a weight of 1.58 kilos. Before transferring to from the outside hospital history, baby was shifted to some NICU in view of respiratory distress and was kept on CPAP and was kept per mouth. Nil per oral. On day of life, 2 baby had asymptomatic hypoglycemia for which glucose infusion was given, which and GIR was maintained up to 6.9 with HGT monitoring. Baby had early onset neonatal sepsis for which antibiotics were escalated to meropenem and vancomycin. Baby took Dama from that hospital and presented in BJ casualty on day of life 6 with complaints of prematurity, respiratory distress syndrome, and hypoglycemia. On admission, there was increase in the leukocyte count with thrombocytopenia, high CRPs, high procalcitonin, and gases of gas was fine. Sugars were slow. Baby was transferred on IV fluids with dextrose of 12.5% GIR of 10 given through PIC line. as the patient had asymptomatic hypoglycemia of less than 25 2 ml per kg of D10, bolus was given from a new IV axis followed by IV infusion which with the GIR of 13. Appropriate antibiotics were started and sepsis part was managed. As overtime sepsis parameters improved, but GIR still had to be increased to 15 to maintain sugars of more than 70. Critical sample was sent in hypoglycemic episode due to persistent hypoglycemia with increasing GIR and improving sepsis bar. So critical sample showed RBS of 40, ammonia of 36, urine ketones negative, insulin more than 2, which it was more than 2, and which indicated hyperinsulinism, cortisol of 2.86. So this is a transient hyperinsulinemia case. Cause can be sepsis or IUGR. Full feeds were achieved at day of life 10 with EBM 35 cc 2 hourly with 1.5 gram sugar and 1 gram cornstarch. These were added to increase the calorific value. Then with a GIR of 11.3 and carbohydrates of 59 grams. Bactec had flashed Klebsiella pneumoniae and appropriate sensitive antibiotics were started. CSF analysis showed meningitis type of pictures. Baby had taken discharge on request with 55 cc of feeds and 3 gram of cornstarch with GIR of 16.8. The feeds were isocaloric and HGT monitoring was advised at home and follow up in HROPD. This case shows that there was definitely hyperinsulinemia as the sepsis part was improving, but still the high were due to high requirement of high GIRs. This might be due to more due to of intrauterine growth restriction cause rather than sepsis. Here in this case, we need to learn that the feeds need to be kept isocaloric. Isocaloric in the sense the calories should be equal to the volume of the feed. Cornstarch provides 4 kilocalories per gram. Sugar provides 4 kilocalories per gram. Breast milk has 67 kilocalories in 100 ml, and HMF provides 3.37 kilocalories per gram. The hypoglycemia caused in IUGR babies is because of the reduced glucose stores. Babies have low glycogen and fat stores, leaving them without an adequate reserve for the energy at birth. There's increased demand of glucose. Baby uses disproportionate amount of blood glucose relative to its size, making it highly vulnerable to low blood sugars and impaired metabolic regulation. The baby's liver enzymes are often immature and the body is less able to produce not able to produce much of glucose and respond properly to the low glucose levels. Transient hypoglycemia in IUGR. The factors that predispose these patients to hypoglycemia include failure of counter regulation hormones, then immaturity of the enzyme system regulating glycogenolysis, gluconeogenesis, ketogenesis, reduced adipose tissue stores, hyperinsulinism or increased sensitivity to insulin. Hypoglycemia in a patient with IUGR is usually thought to be transient, lasting for a few days. But the GIR should be maintained within this span of time to avoid hypoglycemic insult. However, the precise duration of transient hyperinsulinemic hypoglycemia is still unclear. This is a graph roughly showing us the requirement, the perinatal stress hypoglycemia, where the small for gestational age infants have low sugar level as compared to the appropriate gestational age, which might be the cause of the transitional neonatal hypoglycemia in IUGR babies. The mean glucose drops lower in SGS and remains below normal for several days up to a few weeks. And during this period of time, the GIS has to be maintained to provide adequate growth and to avoid hypoglycemic insults, if any. Yeah, thank you.
Thank you. I'll request the SGPGI team to please take over.
Hello. Am I audible?
Yes, you're
Dr.
audible. Go
Shivan.
to full screen.
So my topic is follow-up and outcomes of refractory neonatal hypoglycemia. Our learning objective will be effect of hypoglycemia, and then neurological outcomes of hypoglycemia, and then brain imaging abnormality of severe neonatal hypoglycemia, effect of hypoglycemia on vision, and follow-up schedule. So what are the effects of neonatal hypoglycemia? There are two types of effect. One is short-term versus long-term. In short-term effect, there is a seizure, acute neurological dysfunction in form of lethargy, apnea, then early developmental delay between 0 to 12 months, poor adaptability and early neurobehavioral concerns, and cerebral palsy. Long-term effects are global developmental impairment, executive dysfunction, visual motor integration defect, fine gross motor delay, and lower academic performance. Neurological outcome, neonatal hypoglycemic brain injury. Hypoglycemia is a surrogate marker of neuronal energy deficiency, which is the major cause of brain injury. Mechanism of the injury is the excitatory neurotoxin, which activate at NMDA receptor. There is also increased mitochondrial free radical generation and initiation of apoptosis also. There is limited glycogen stores in astrocyte that provide immediate supply of glucose to the neurons. This mechanism can protect the brain for limited periods, and permanent damage occur if recurrent protracted hypoglycemia prevails. There is increased risk of cerebral palsy, developmental delay, and low mental score at 18 months of age, which has been shown in the infant with recurrent hypoglycemia events. The pathological changes in NHPI includes swelling of neuronal and glial cells, necrosis, gyrus atrophy, and white matter demyelination. Brain imaging abnormality. The major finding is occipital with or without parietal lobe lesion seen in 75% of the cases. Then cortico-spinal tract involvement in 15% cases. Then watershed abnormality in 10% cases, and MRS shows no or mild elevation in lactate. This basically differentiates it from perinatal asphyxia, where the lactate elevation will be seen, and only 10 to 15% of the above lesion resolve in time. The long-term neurological sequelae is developmental delay or mental retardation that is seen in 84% cases, seizure in 66% cases, visual impairment in 37% of the cases, and microcephaly in 32% of the cases. Vulnerability of certain area, why this posterior cerebral cortex is more involved in hypoglycemia, because the active dendritic organization and synaptogenesis, then high concentration of oligodendroglial precursor cell, high energy needs of posterior cerebral cortex, and development of excitatory amino acid receptor. Also, the upper cortical neuronal layers that is close to CSF and excitatory amino acid born in CSF. Neuropathological sequelae is atrophy of the gyri, widening of the sulci, then dilated lateral ventricle, then injury to the cerebral cortex, and demutation of myelinated cerebral white matter, and finally this all leads to microcephaly. Pattern of cerebral injury and neurodevelopmental outcome after symptomatic hypoglycemia. This study was done. They studied 35 term infant with early brain MRI scan after symptomatic hypoglycemia. The median glucose level was 1 millimole per liter without evidence of HIE. And neurodevelopmental outcome were assessed at the age of 18 months. So what they found is, this is their finding, that white matter abnormality occurred in 94% of the infant with hypoglycemia, and that was severe in 43% of the cases with predominant posterior pattern in 29% cases. They found cortical abnormality in 51% of the infant, and 30% had white matter hemorrhage, 40% had basal ganglia or thalamic lesion, and 11% had abnormal posterior limb of the internal capsule lesions. So this is the image. You can see the restricted diffusion in DWI image of MRI, which shows the involvement of splenium of the corpus callosum. In second image, we can see that loss of gray and white matter diffusion in parieto-occipital area. This area has loss of gray and white matter differentiation. And the third image, which shows the atrophy in the parieto-occipital area, which is seen here. There is the prominent of the sulci, which signifies that atrophy is there. Then neurological outcome after neonatal hypoglycemia. This study was done by Covisto. They followed up the cases at 1 to 4 years of age, and they found that neurological feature like seizure in 50% of the cases. Then neurological feature, but there was no seizure in 12% of the cases, and no neurological signs in 6% of the cases. And 38% of the case were normal. And then in normal percentage, there was no neurological feature in 80% of the cases. Then another study which was done by Lucas et al. In 1988, they found that in preterm infant, if the duration of hypoglycemia is more than or equal to 3 days, then percentage of neurodevelopment impairment is 29%. If the duration was more than or equal to 5 days, then the neurodevelopmental impairment was 42%. And if more than or equal to 7 days of hypoglycemic episode was there, then the neurodevelopmental impairment was 40%. So the first study, which was done by Lucas et al., which the finding at 18 months of the developmental age shows that the point was lower by 14 and motor developmental score lower by 13 point, with increased risk of cerebral palsy or developmental delay. Risk factor was recurrent hypoglycemia for 5 or more days. Another study which was done by Brand et al., which studies transient mild to severe hypoglycemia, and the incidence happened within first 1, 3, and 5 hours afterward, and they studied the hypoglycemic evidence incidence with less than 2.2 millimole of glucose, and they did not find any overall negative effect with in their study. Another study which was done by Christopher et al. This is child study, which is association of neonatal hypoglycemia with neurodevelopmental outcome at 4.5 years of age. What they found, objective of the study was to hypothesis the neurodevelopment at 4.5 years of age related to the severity and frequency of neonatal hypoglycemia, and it was a prospective cohort investigation of moderate to late preterm infant and term infant who were at risk of hypoglycemia. And this study was done in New Zealand. The study was conducted from December 2006 to November 2010. And the main outcome was cognitive function, executive function, visual function, and motor function assessed at 4.5 years of age. And primary outcome was neurosensory impairment, and that was defined as poor performance in one or more domain. So the result of this study was those exposed to the neonatal hypoglycemia did not have increased risk of neurosensory impairment. However, the hypoglycemia was associated with increased risk of low executive function with a relative risk of 2.32 and visual motor function with relative risk of 3.67, with highest risk in children who are exposed to severe, recurrent, and clinically undetected hypoglycemia. So the conclusion of the study was neonatal hypoglycemia was not associated with increased risk of combined neurosensory impairment at 4.5 years, but was associated with dose-dependent increased risk of poor executive function and motor function, even if not detected clinically, and may thus influence the later learning. This study was published in JAMA Network. This was systemic review and meta-analysis of neonatal hypoglycemia and neurodevelopmental outcome. So the result of the study was a total of 17 studies were included in this meta-analysis, and neurodevelopmental impairment was significantly higher in early and mid-childhood in infant with neonatal hypoglycemia. Any cognitive impairment was significantly more common in infant with neonatal hypoglycemia. Visuomotor impairment and executive function were also more common in the hypoglycemic group. However, there is no difference in incidence of epilepsy, motor impairment, emotional behavior problem, and hearing impairment were noted in this meta-analysis. Another study which was published in JAMA Network was the transitional neonatal hypoglycemia and adverse neonatal outcome in mid-childhood period that was done by Roper et al. So objective of this study was to evaluate whether the occurrence of severe transitional neonatal hypoglycemia that was defined in this study of blood glucose of at least one measurement of 30 milligram per deciliter or below is associated with adverse neonatal development in mid-childhood. So this was cohort study using neurodevelopmental testing of a retrospectively recruited cohort was conducted in single center tertiary hospital in Germany between March 2022 to February 2023. So exposure group, at least one hypoglycemic event was noted, and they found that they showed a 4.9-fold of increased odds of abnormal fine motor function and 5.3-fold of increased odds of visual motor integration. And this was associated with significantly high T-score of attention problem also. So the conclusion of this study was that neonatal hypoglycemia with blood glucose level of 30 milligram per deciliter or below was associated with increased risk of suboptimal neurodevelopmental outcome in mid-childhood period. Another study which was done, this is systemic review, which was neurodevelopmental after neonatal hypoglycemia. They searched mid-time embase for cohort study on subsequent neurodevelopment after episode of hypoglycemia in first week of life. They studied 18 eligible studies. Out of this, only 2 studies were selected for the further study, but none of the study provided valid estimate of the effect of the neonatal hypoglycemia on neurodevelopment. Building on the strength and weakness of the existing studies, they developed the proposal of optimal future study to study further the development, neurodevelopment in case of neonatal hypoglycemia. So what are the effects on vision of neonatal hypoglycemia? So Carbollo et al. In 2004, they studied 15 patients with epilepsy and or posterior cerebral lesion with history of neonatal hypoglycemia, and 8 had visual disturbance. Similarly, Tam et al. In 2008 did a retrospective cohort study in 45 neonates with hypoglycemia. They found 33% of the neonate who had hypoglycemia lasting for more than or equal to 2 days had cortical visual loss, which was correlated to the MRI finding of diffuse restriction of the occipital lobes. And then Kazi Remdel et al. In 2011, they studied 27 patients with seizure and hypoglycemia and compared with 28 patients with idiopathic occipital epilepsy. They found that 17 out of 27 had visual disturbance, of which 8 had visual loss. In control group, only 2 out of 28 had visual disturbance. And in 20 out of 27 of hypoglycemic group showed occipital and parieto-occipital lesion in control. Then Keudel et al. In 2017, the population size is not exactly clarified in that study. However, they found that no clear evidence for effect of neonatal hypoglycemia and visual disturbance, and they suggested that further research is needed in this topic to see the effect of hypoglycemia. So this study shows that there is a significant effect on visual disturbances in hypoglycemia. Then infant with hypoglycemia have been reported to exhibit a typical pattern of CNS injury, particularly in parieto-occipital cortex and subcortical white matter. However, it is often difficult clinically to separate isolated hypoglycemia from HIE plus hypoglycemia. Then Rosens and Hay et al. In 2016 conducted a review of neonatal hypoglycemia literature in attempt to determine with how low concentration and duration of the hypoglycemia and association with clinical sign might indicate potential long-term injury. So what are the risks of long-term neurological impairment? So if the blood glucose or plasma glucose concentration falls below 1 millimole are abnormal, although if transient, there is no permanent neurological injury. Early mild to moderate clinical signs or even a brief convulsion, then more clinical signs that are prolonged, many hours or longer, including coma, seizure, respiratory depression, or concurrence of associated condition, particularly hyperinsulinemia. So it has been seen that hyperinsulinemia was associated with more neurological impairment in the babies. Now, the second part is follow-up schedule for refractory neonatal hypoglycemia. So from NICU discharge to 3 months, the visit frequency is weekly for the first 2-3 weeks, and then every 2 weeks until 3 months. And we assess length, weight, head circumference, glucose log, continuous glucose monitoring pattern. If the baby is on medication, then medication tolerance should be assessed. Then BP and echocardiography status for diazoxide. Then feeding issue, poor weight gain, and neurological examination. We can check the tone and reflexes. Then between age 3 to 6 months, the visit frequency is monthly and should assess the developmental milestone, vision screening, then hearing screening, then review need for octreotide and sirolimus dose adjustment, and risk of hypoglycemia during illness or vaccination period, and MRI brain review can be done at this stage. Age 6 to 12 months, the visit frequency is every 2 months. Visit frequency is every 2 months, and neurodevelopmental assessment by Bailey scale 3, then growth velocity, endocrinological screening, fasting glucose and HbA1c level, then feeding advancement and weaning, and reassess recurrence of hypoglycemia during intercurrent illness. And for post-surgical cases, stool elastase for steatorrhea is suspected. From age 12 to 24 months, the visit frequency is every 3 months, and we can assess the comprehensive neurodevelopment, Bailey 3 or Griffith, then cognitive function and behavior, eye examination plus visual field examination, motor tone because there is a risk of CP, and endocrine assessment. We can check HbA1c and OGT if pancreatectomy was done, and repeat MRI can be done if the development is abnormal. Between age 2 to 5 years, the visit frequency is every 6 months, and we should assess the speech, language, learning skill, then behavioral screening like ADHD like symptom, then vision annual review is done, and endocrine growth chart, fasting glucose and HbA1c level is also checked. Then continue monitoring of late hypoglycemia or hyperglycemia, and school readiness screening was also done. So the follow-up summary is outcome depend upon duration, degree of hypoglycemia, rate of cerebral blood flow, and cerebral utilization of glucose and other comorbidities. Then on follow-up, look at neurodevelopment, IQ reading ability, arithmetic proficiency, and motor performance. Infants should be assessed at 1 month of corrected age for vision and eye evaluation. And at 3, 6, 9, 12, and 18 corrected month, they can be followed for growth, neurodevelopment, vision, and hearing loss. And MRI at 4 to 6 weeks will show hypoglycemic injury subjected for affordability. So the take-home message is early detection and maintenance of glucose more than 47 milligram per deciliter prevent major neurodisability. This was taken from a child study. Then subtle neurocognitive deficit may still occur despite of the treatment. then all newborn with severe recurrent symptomatic or hyperinsulinemic hypoglycemia need long-term structural follow-up, and long-term risk also depend upon the cause. Like hyperinsulinemia has a link with more neurological damage in later in the life. So with this, I end my presentation. Thank you.
Thank you, Dr. Shinil. I think we've already passed our prescribed time limit. It's a request to all the institutes, to all the residents to please stick to the timeline. I think MMR team couldn't join. We will contact them later. If you have any comments or doubts, you can please take.
Only comment is to second Dr. Chinmay's comment that one should be brief about the presentation so that we can have some room for discussion. So there is a way that people can stick to the time, and it's for everybody. Thank you.
Right, ma'am.
I think we can close the session.
Sure, ma'am. Thank you, everyone.
Thank you.